Welcome everyone to the second session in day one. We're very excited to talk about a very big burgeoning topic under the general title of genetic profiling. And what we want to do here is really to explore what genetic profiling is all about. We suspect that there's various different levels of knowledge about what genetic profiling is, how you can access it, how you can speak to your medical team about it, what tests are standard, when you do it. All of those things we're going to explore today, and we have two amazing people to help unravel this conversation with us. I first want to introduce Gordon Levine, who, born and raised in Montreal. Gordon's been on a number of colorectal cancers Canada's sessions because he's such a tremendous patient advocate. He spent his career practicing commercial law, although in November of 2014, at the age of 48, Gordon learned that he had a malignant tumor in his colon. Over the next 4 years, Gordon underwent several surgeries and various lines of chemotherapy, which put him into 2 brief remissions. In early 2018, the cancer recurred, this time having also spread to his abdomen, liver, lung, and bone. Gordon enrolled in a clinical trial, and while the treatment showed early promise, CT scans later that year indicated further tumor growth. Having exhausted a number of the available treatment options in Montreal, Gordon sought a second opinion in San Diego. Next generation genetic sequencing indicated that Gordon might respond to treatment with a combination of 2 immunotherapies. After 3 immunotherapy sessions, Gordon was able to reduce his pain medication and live an active life again. Treatment ended in the summer of 2020, having resulted in the eradication of all the cancer, save for a resistant area in the sigmoid colon. In the spring of 2021, Gordon underwent surgery to remove the remaining disease and create a permanent ostomy. After responding to the immunotherapy treatment, Gordon became active in patient advocacy. We're so grateful for his time today. As an immuno advocate for cancer research in general at the Institute, and as I've mentioned, Gordon has been a very profiled part of the colorectal cancer community, and we're very happy to have him with us today. I also would like to introduce Dr. Selvarajah, who is currently a clinical molecular geneticist in the Division of Clinical Laboratory Genetics at the University Health Network here in Toronto. Her academic interests are focused on genitourinary cancer genomics and biomarker development through the application of high throughput technologies. She's an assistant professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto, and has been actively involved in teaching undergraduates and medical students in the area of cancer genetics. So 2 excellent speakers to help us get into the subject of genetic profiling today. Welcome. Gordon, I'm first going to go to you, and while I've told quite a bit about your story, I'd really love you to share the details of your experiences, particularly as it related to genetic profiling.
Thank you. It's a pleasure to be able to participate once again with Colorectal Cancer Canada. As you stated, Anne-Marie, I was diagnosed almost 9 years ago at age 48. At the time of diagnosis, I was stage 3. And there wasn't much of a discussion about genetic profiling at that time. After I had finished chemo, there was a meeting with a geneticist at the hospital. They had mentioned that if I had a hereditary protein, then they would probably recommend removal of the entire colon in order to prevent a recurrence. The geneticist indicated to me that I did not have this hereditary protein, and that there wasn't a hereditary component to the cancer. And we left it at that, as I was in a remission period. In 2016, I had a recurrence, and this time the cancer had spread to part of the abdomen called the peritoneum. So I was now stage 4. I was not really asking about genetics at this time because I was really more in shock, having to deal with a diagnosis of metastatic disease. And I had to undergo a very lengthy and complicated surgery that not only removed the cancer, but they gave me HIPEC, which is where they put chemo into your abdomen while you're on the operating table. I had a temporary ostomy at the time, and then went through another round of chemotherapy. And after that, they reversed the ostomy and told me I was in remission. In early 2018, I had a second recurrence, and this time the cancer had spread into my liver and lung and abdomen and bone, including a very painful bone met in my right hip. At this point, I did have a discussion with my oncologist. I had a friend who was stage 4 who was trying immunotherapy, and he mentioned protein mismatch to me. And I remember speaking with Barry Stein, who told me I should ask about protein mismatch. So I had a conversation with my oncologist, who told me that I did not have protein mismatch. And actually, he provided me with a copy of a pathology report, and the report is dated September of 2016. So that means that this testing was done when I had my first recurrence. But I wasn't aware of the report until 2 years later. And the report says nuclear immunostaining for the mismatch repair proteins MLH1, MSH2, MSH6, and PMS2. There is no evidence of mismatch repair protein deficiency by immunohistochemistry. My only understanding from this was without protein mismatch, getting immunotherapy would maybe not work as well. Nevertheless, I was able to enroll in a clinical trial where I received the immunotherapy drug Keytruda along with another drug. And initially, I felt better on that treatment, but ultimately I did have progression and I had to exit the trial. So at this point, I had disease spreading through my body. The pain was worsening, and my treatment options were becoming very, very minimal. So I was able to get a second opinion consult with Dr. Miller at UCSD in San Diego. But before he would give me a second opinion, he told me that I needed to have next generation genetic sequencing done. And he helped me arrange to have this done at a company called Tempus. And the advantage of Tempus, according to him, was that they would sequence 1,700 genes and also do germline sequencing. I did not see the report right away, but when the report was sent to Dr. Miller, I had a phone call with him, and he told me that they found a germline variant of unknown significance in MSH6. And based on that, he suggested that I fly down to San Diego and meet with him for a consultation, which I did in late 2018. The report itself, which I received at that time, is quite detailed with a lot of technical terms. But the bottom line was that this gene that they found a mutation in is related to Lynch syndrome. The doctor told me that I did not have Lynch syndrome, strictly speaking, but he felt that given my history and my family history and the findings from the sequencing company, that he would treat me like he would for Lynch patients, which was with the two drug immunotherapy combination. And as you stated, Anne Marie, after a few rounds, my tumors began to shrink. In fact, Dr. Miller had called me very excited after a CT scan to come down to his office and look at the pictures, and he showed me the comparisons. My pain started to reduce. I was able to get off the pain meds and start exercising. And I continued on this treatment for a year and a half until the summer of 2020. And then ultimately I had that surgery. So I did end up having my entire colon removed at the end of the day. And since then, as you mentioned, I've been doing a lot of patient advocacy. And part of the message that I give to patients and what we're trying to do today is, unlike what I did, try to ask questions about testing and get your reports sooner rather than later. Don't wait 4 or 5 years before you find out what's going on with your biomarkers. And even though I was lucky enough to be able to have access to all of this testing, time is really of the essence. So with that, I'm going to hand it over to our expert biologist to explain some of the specifics of these tests that I received.
Thank you so much, Gordon. And I really appreciate the succinctness of your story. And as I've always said to you and for our audience, Gordon is rather extraordinary in his capabilities and ability to understand a lot of the data and the testing that's essentially he's been involved with. So I think what we're going to get some help with from Dr. Selvarajah is to understand some of this terminology, understand some of the processes around when and how we get there. So I'm gonna let you start the conversation, Dr. Selvarajah, and at any point you think is valuable, and then we'll unpeel it from there.
Yeah, sure, definitely. Thank you. So I think maybe the first thing I'll start talking about is this mismatch repair protein that Gordon mentioned. He found out early in his treatment journey. So we have all our information is coded in our DNA, and we have different mechanisms that are out there to repair DNA when there are errors in it. And the type of mechanism that's used to repair the DNA depends on what type of mistake is occurring there. So mismatch repair pathway is a type of repair pathway that we have. I think it's one of the 5 most well-characterized DNA repair pathways. In this pathway, you have 4 key proteins that is used by pathologists when they do a certain type of staining called immunohistochemistry. And that's the one that Gordon actually mentioned before. So you have 4 genes that code for these proteins. So you have MSH2, MSH6, PMS2, and MLH1. So what the pathologist does is they will use certain stains to see if there's any kind of abnormal staining with any one of these proteins. And if there is abnormal staining, then there is an algorithm for them to follow to determine if this patient may have an underlying hereditary condition. And I'll go into, inherited and acquired in a bit, but basically this staining is to determine that. And based on which protein is showing an atypical staining or lack of staining, there is a specific downstream algorithm to follow. So in Gordon's case, it looked like everything was normal, and so there was no follow-up. Now, these 4 proteins are actually quite relevant in something called Lynch syndrome, which Gordon mentioned. And this is a hereditary syndrome where you can have inherited mutations in one of these genes. And now families who have Lynch syndrome, there's a certain pattern. If you look at the pedigree, and the pedigree is a term we use for this diagram or flow chart that sort of shows the different generations. So we'll have grandmother, grandfather on each side of the family, the parents, siblings, cousins, and it indicates what kind of tumor that the different individuals would have had. And so in a family where you have Lynch syndrome, you would see, number one, there is a unusually high incidence of certain cancers such as colon cancer, endometrial cancer. So there are a few cancers that you see in Lynch families. And so you'll see a higher incidence than you would in the general population. The other thing that really is very striking in Lynch families is these patients will be diagnosed quite early on. So rather than much later in the disease, like much later in life, like 60, 70, 80, you would have diagnosis, in your 30s, 40s, 50s, 60s. And it seems to vary for the different genes, but generally these are the two main things that strike you about Lynch families. And so the reason they do this testing for mismatch repair protein is to see if there's something unusual about the protein. And if there is, with the immunohistochemistry test, which is what they did with Gordon's tumor specimen, then they would follow that up with additional tests.
Okay.
That is
would you mind if I stop you there? Because you've said so many really important things. I want to make sure people understand this. So is it standard of care to get this protein mismatching test? Or do you have to show up with a family history of colorectal cancer? Or at what stage does this testing actually get introduced to the conversation?
Yeah, so this type of test will only be done on the tumor itself, like the test that Gordon described, which is issued by a pathologist, is performed by a pathologist, and that is done on tumor. So unless a person has a family history and also has a tumor, they will not get this specific IHC test. They will get a different type of test that involves a blood test. That's to determine if you may have Lynch, which is an inherited alteration in your DNA. So when there's a question of, okay, let's say one of the proteins showed abnormal staining, then the recommendation would be for the patient to have germline testing, which is basically looking at your blood to see if the DNA has any alteration. And in those cases, you're looking at inherited alterations. So you inherited from your father or your mother, and you would identify potential inherited alterations by doing something called next generation sequencing of the DNA from your peripheral blood or your white blood cells specifically.
So in all of that, what exactly is genetic profiling then? Because we've used some really big terms and there's been a number of different tests. I'm going, well, so is a genetic profile test something different than all of that? Or is it part of this? Maybe we can start there too.
So genetic profiling, there are different types of genetic profiling. So the first test on the tumor that was done, that was not actually, even though you're looking to see if there's a potential alteration for the gene, you're actually looking at the protein. So that part itself, that test, which we call immunohistochemistry, IHC, is not a genetic profiling test. But if there's something abnormal with the protein, then you will try to see if something's wrong with the gene. And that's when you start doing the genetic profiling. Now, for colon cancer patients, at least in Canada, there are two different types of testing. So the first test for patients, before it used to be under 70, but I know in Ontario now it's any patient who comes in with colon cancer, that tumor undergoes the immunohistochemistry testing on the protein that Gordon had. If the patient has advanced colorectal cancer, then there's a type of genetic profiling that is done called predictive testing. And the reason they call it predictive is they're going to try to see if the tumor has certain types of mutations in certain genes, and I will list those genes out later. But what it tells you is how that patient will respond to certain therapies. So this doesn't have anything to do with the inherited aspect. It's more of your response to a drug, targeted therapy. So these genes you might see in a report like KRAS, BRAF, PIK3CA, and there might be patients in the audience who will recognize those genes because that is something certain patients get this is genetic profiling that would happen on their tumor. And the purpose is to see if you have certain alterations, and depending on what alterations you have, it tells you give this drug or don't give that drug, you give this drug or you give this combination. So that is
in essence,
tumor
genetic
profiling.
will help determine the therapy that I go on.
Yeah,
is that correct?
Yeah, it will determine, the clinical management, and that is what they call predictive. When you hear the word predictive, it's actually talking about the drug. Now, another type of genetic profiling is the one that happens when you have abnormal protein with that first test, that immunohistochemistry I mentioned. If there's an abnormal protein and they think, maybe this patient might have an underlying germline variant, then they would actually recommend your blood, your white blood cells, for the DNA to be extracted from there and sequenced to get germline status to see if you might have an inherited variant. So they're trying to identify Lynch patients. And that is also called genetic profiling, but that's what you call germline. So germline is referring to any kind of testing where you're trying to see if you inherited something, whereas the acquired is a mutation that you just acquired, basically, but after you were born. It's not germline.
So if someone actually came in and said, I have a history of Lynch in my family, would the medical team automatically go into a certain stream of testing, or would they actually go into germline to validate and to
it depends how the patient actually comes to the clinic. So if this is an individual who doesn't have a personal history of cancer, but they have lots of individuals in their family who have cancers that sort of fit into the Lynch that pattern, then what happens is actually it's the person with the cancer who will get tested first, because you're more likely to identify a germline variant by actually looking at the person with the cancer. Because with these mutations, you have a 50-50% chance of inheriting it. So just because your father or your mother has a variant doesn't mean you automatically get it. You have only a 50% chance of getting that mutation from your father or your mother. And so they usually will test the patient. And they will do the germline test. But let's say you're a patient who already has the tumor, then what happens is you would be you would have the tumor test for those 4 proteins to see if there's abnormal staining. And based on that, you would get the follow-up germline test to see
so
if
Gordon, as you were going through your story, were you aware that all of these things were going on? Was this something that was discussed with you? How did that? What was your experience?
Yeah, like I mentioned, there was a discussion about a protein, which I now know was the staining of those 4 proteins, and but what we didn't realize at the time when I met with the geneticist was that I had a first cousin that passed away in her young 50s from endometrial cancer. That was number 1. Number 2, because the staining test came up negative for protein mismatch, it was kind of not thought relevant to pursue further in my case. However, when I went to see Dr. Miller, and he said, number one, you're 48 when you get colon cancer. As Dr. Selvarajah said, that's young to get this. You had a cousin who died very young from an endometrial, which is especially related now, I know, to MSH6. And you've got this variant of unknown significance in your germline. And we also discovered that because we feel it came from my mother, her other sister also has this mutation, the same mutation. And she ended up developing a cancer, but later in her 70s. But all of this were factors in the doctor thinking that even though it's not classic Lynch because the IHC test was negative, that there could be a strong likelihood of a genetic inherited component to my cancer.
Mm-hmm.
And because of that, I had my daughters tested. And one of my daughters has this mutation. So we're doing some monitoring for her. It's not guaranteed that she'll develop cancer, but it's something that we're keeping in mind in terms of her own medical care going forward. So this for me personally, even when I learned about this, I felt that even if ultimately treatment would not succeed for me, I learned something about my family history and some information that's very relevant for my daughter to know. I don't know if in 10 years from now, when we reconvene, this variant of unknown significance maybe will be found to be related, or maybe it'll be something that just was coincidental. But for the time being, this is information that's really important, not just for my own health, but for my family's health as well.
Yeah.
And actually, something else I wanted to say is there are incidences, and it doesn't happen very often, but it's known. And this is something, as time goes by, we learn more and more about these genes and their behavior. Is you can have an instance where there's actually a mutation at the gene level, but when you look at the protein, you don't see any abnormal staining. So the staining looks normal, but when you do a germline, you see that there is that mutation, and there's not much information on that mutation. And so I think part of the reason why your oncologist thought you might respond to immunotherapy is because we know that not every mutation will lead to a change in the protein staining pattern, but it could impact the function, as in its ability to repair.
One of the things that I did learn is that when we talk about somatic testing, which is testing of the tumor, they may find mutations in the tumor. But when you have a mutation in your germline, meaning it's found in a blood test, that mutation is basically in all of your cells everywhere in your body. So it's not like just because it's in the blood, it's not in the tumor as well. So it's an important little detail that I also learned through my journey.
Thank you for sharing that.
It will be in every cell.
Yeah. I wanted to bridge into, so is next generation sequencing something different than what we've just talked about here? Is that another level of testing, and when is that done? Or is this more language that we just need to make sure we understand?
Yeah, so next generation sequencing, it's something that has been around now for 10 to 11 years, but it wasn't really in the past, I would say, 8 years that it has really started to be used routinely in the lab. So that protein test that was done, you don't use NGS for that. For that, you do a staining test. But for the kind of molecular testing that we do nowadays for colon cancer, whether it is germline or we're looking at tumor, the somatic testing that Gordon mentioned, we use something called next generation sequencing. And we call it next generation sequencing because before this NGS, the acronym for next generation sequencing, we used to look at a single gene and actually a portion of the gene because the assays that were available at the time were quite limited. But what next, and you can do it only on one patient at a time. So you have these experiments or this testing where you can only look at one area of the gene for one patient at a time. But what NGS allows you to do is, depending on how you design the test, you can look at the whole gene and you can test 20 patients at the same time. So that's why they call it next generation sequencing, because now you can look at so much more and you can test so many more patients. Like another term they use is massively parallel sequencing, because you're basically sequencing millions and millions of sequences. So it really is next
I think
generation.
I'm going to need a dictionary soon just to keep track of all of this terminology.
Yeah.
So Gordon, I've understood that you've had next generation sequencing twice now. Is that correct? Or am I
Technically,
incorrect?
yes. Well, actually, it's interesting because when I did look at this pathology report, I noticed that there's a note that they sent the tumor for BRAF and KRAS or RAS testing at the time, and I never even got results from that. But they did. The hospital did send my tumor out for NGS to one company, and it confirmed that I do have a KRAS mutation in the tumor, and I did not have a BRAF mutation. It also found APC mutations, which are very common in cancer, but also there are no treatments that can attack those. And then I had the second sequencing done, like I said, at Tempus. And the reason why Dr. Miller preferred that was because they also did the germline sequencing. And that's where they found that mutation that kind of turned on the light bulb, I guess, for the doctor. And the other thing that I'm understanding from NGS is the more sequencing that's done, the more data is being collected. And ultimately, I think AI is going to have a role in all of this, is to try with large numbers of sequencing of many variants to hopefully target more specifically which treatments are working for which variants they're detecting. And that'll be something I guess we'll see evolve over the next number of years. But yes, I did have the testing done. And it's interesting because the first testing that did come back that only looked at the tumor concluded that immunotherapy would not work for me. And that it colored my local oncologist's perception of treatment, because he did not expect it to work. And then when I had it in the clinical trial and had progression, it kind of confirmed what he suspected. But luckily, there was more to the story in my case.
Yeah.
So in Gordon's case, it would have been the results of the protein test that had an impact on the oncologist thinking, determining whether he will respond or not respond to immunotherapy. The one with KRAS and BRAF and APC, that is what I mentioned before, was called predictive testing. And that is what they do for determining whether the patient is eligible for any kind of targeted therapy. So the kinds of therapy, you can have chemo, which is very general. It destroys a very large number of cells, can be quite toxic, versus what they call targeted therapy, where it actually attacks the specific aberrant protein rather than just any healthy cell. And so that's what they did this other testing for you on, looking for BRAF, KRAS, APC, and all.
Right. With KRAS, in my experience, what it did was eliminate certain treatments that would not work. However, they are doing clinical trials right now to try to target KRAS mutations because
Yeah.
around half of colorectal cancer has a KRAS
Yeah.
mutation.
Yeah.
Right.
And now there's actually a drug that is used for a specific type of KRAS mutation. KRAS was sort of considered the untargetable, undruggable target because it was so difficult to design a drug that can target alterations, mutations in this gene. But things have changed quite a bit in the last, 2, 3 years now. There's been a lot of progress made with regards to targeted therapy in genes in that pathway.
Right. It is shocking how quickly we can go through 35 minutes. And this is such a rich,
Oh,
deep
wow.
conversation. It's a very complex conversation, too. So, Dr. Selvarajah, what I'd really love you to do is for someone in our community today who is assessing various different treatments, how does the subject of genetic profiling fit into their conversation on a really basic level? Where does that conversation get initiated from? What does someone in the community going through cancer need to know about this specifically, and what kinds of questions can they ask to ensure that they feel informed all the way through?
Yeah. So, I always think patients are their own advocates, they're their own best advocates. And I think, what I would say is for a patient, if they have colorectal cancer, the important thing is just to ask the medical oncologist what type of genomic profiling will be done on my specimen and what type of additional testing will be done. This protein test has been, it's been done for so many years now. It's pretty standard, as is the genetic profiling, depending on what stage of cancer you are. So if you're in the early stages of cancer, you don't get the same type of genetic profiling as you do if you have metastatic or advanced colorectal cancer. And I think this is where the patient can say, for the stage I'm at, what is the kind of testing that will be done on my tumor? And should I consider any kind of inherited cancer? Like, should someone take a look at my family history? And so I think just starting that conversation is important.
Great,
Because
perfect. Thank
the
you. Thanks
treatment
for making that
algorithms
so
are very
clear.
standard. Yeah.
Yes, thank you. And Gordon, I will give you the last and final word before we move into a question period. I'm confident that our community will have a lot of questions about this. Final word, what advice would you give to somebody in
Well,
terms of,
I mean, I
because
would
you,
echo exactly that. Ask about the tests, but also don't be shy to ask for the reports. Your hospital file is your file; it belongs to you. We're sometimes shy about this. Most of the doctors now, they have computers in the little room where they're examining you. They can often print out right from that terminal, or they may send you to their assistant. Get copies of the reports. And also reach out to us, the patient advocates with experience. I've read lots of these reports now. I'm not a medical doctor. I'm not a molecular biologist, but I'm familiar with what the reports say. And we're here. There's a lot of us. We're resources too to help you analyze, because when you're in a waiting room getting examined, you're not thinking of all the questions. Your head isn't thinking about details in reports. So ask for the reports, and then seek out us in the community for help, because that's what we're here for.
thank you, Gordon. You're always incredibly generous with your time, Dr. Selvarajah. Thank you for such an expansive, deep conversation. I wish we had more time, but we are going to move now to Q&A. Welcome, everyone. And as we promised, we are going to have a wonderful Q&A session. We've already got dozens of questions coming in. Thank you so much to our audience for your interest, your enthusiasm. Please keep those coming. Gordon, unfortunately, had to leave and cannot attend this Q&A, but we're very, very privileged to have Dr. Selvarajah still with us, who is very prepared to answer as many questions as she possibly can in the 15 minutes or so that we have. So let's get right to it. I'm going to ask the first question from Iris. for the testing that influences treatment, should they be done again if there is a reoccurrence?
So I think it's important for, if it's a reoccurrence, I think the first thing is to determine is if that is an actual reoccurrence. So this is where you might need another biopsy, and for the pathologist to look at the tissue or the specimen to determine if the histology suggests it's an actual reoccurrence of the same tumor, if it's a different primary. And after that, we can do testing on that new specimen. So it's important to determine if that is a reoccurrence or not.
Yeah. And could you just clarify the process on that? How would who would direct the testing that you suggested here to actually dig into the fact that there is or is not a reoccurrence?
So it
That
would be
would
the
be the
pathologist. Yeah.
pathologist.
So
Okay.
the oncologist or surgeon will send the specimen to the pathologist. Pathologist will then examine the tissue and determine if it is the same or it's a new primary. And based on what they find, then they would send it to us for molecular testing. So sometimes if it is a reoccurrence, then what's going to happen is we will see the same mutation. Whereas if it's an entirely different tumor, it may have a different profile, like if it's an entirely different primary.
Yeah. Thank you. And that actually is a wonderful bridge into the next question, which is from Natalia. Do you normally find the same mutation pattern in liver, peritoneal, lung, etc.?
Okay, so generally, when you are looking at the primary tumor and metastatic lesions, so the metastatic tumor, the major drivers will remain the same. However, because you have sort of a disease progression and the patient undergoes different kinds of treatment, there is a selective pressure on those tumors. So the profile changes slightly because you would acquire new mutations. Some will be passenger mutations. Some will be relevant to the spread of that tumor from the primary to the metastatic lesion. But generally, the major drivers will be there.
Okay. Okay. Also from Natalia, is it advised to retest tumor for mismatch repair enzyme deficiency if the disease reappears with a different metastatic pattern in a patient with intact germline and MSS at time of diagnosis? That's an awfully big question, and I'm hoping that I phrased that appropriately. Thank you,
Yeah, I'm
Natalia,
just
for
repeating it
really
here.
you. Yeah.
Is it advised to retest tumor for mismatch repair if the disease is reappears a different metastatic pattern?
In a
Yeah,
patient with.
if if there's any question that it is not the same tumor type, then it's best to actually perform that MMR IHC test again. If there's any question that it's not, like if it's having a different spread pattern, metastatic spread pattern, you want to make sure that you retest it.
And again, who would make that decision? And is the patient involved in that conversation?
Well, if there's going to be a biopsy, it's like another new biopsy for this patient, then of course the surgeon or the oncologist will be speaking to them about it.
Mm-hmm.
But once a specimen is sent off to pathology for processing, it's a pathologist that sort of triages what kind of protein test should be done at the beginning, and then they will determine if you need to send for any kind of molecular testing
Okay, fantastic.
and genetic testing. Yeah.
Yes. Sheila has asked a question, which is, can Lynch syndrome be detected with a saliva test or only a blood test?
No, you can. Like some labs are validated to actually perform the germline test on saliva. Blood is the most frequently used specimen type. However, what I have found is in the last couple of years with COVID, where you have individuals are hesitant to go into, say, a lab to have their blood drawn, there's been more of a interest in using saliva to do the germline test.
Okay. Okay, great. So, a lot of we use the word test a lot. And we've learned from other sessions that some of these particularly novel and emerging tests are not covered through provincial health plans and so forth. Is this the kind of testing you do covered?
So yes and no. So the basic test, which is like the very first test when the specimen comes into the lab, it's a protein IHC that's performed by the pathologist. So that's standard for colon cancer. And then if the patient has advanced metastatic colon cancer, they will undergo something called predictive testing, which, as one of the previous attendees asked, these are the ones to determine if you're eligible for treatment. So for that, you have the RAS testing, and that's usually covered by most provinces because they follow guidelines. But then you do have additional genes which certain labs will test, and that's because there might be sort of internal studies going on where clinicians have obtained funding to look at the status of additional genes so the patients can be enrolled in clinical trials. So the cases where you have this expanded panel testing more often is seen in larger academic sites because that's where you have the clinicians that are sort of more easily able to muster support of funding from pharma to have patients enroll in these studies. So the basic, like the very core of RAS testing in colorectal cancer, that usually is covered, I believe, by probably almost all provinces in Canada.
Okay, thank you for sharing it. So a person, before they experience any of these tests, of which there's many, really needs to have the discussion with their oncologist about what is covered, what is not covered. Is that a conversation that would typically come up in conversation, or would that be, are patients encouraged to ask those questions themselves?
So, honestly, because I'm not a clinician, I don't see patients. I'm a molecular geneticist, so I don't really know of the kind of conversation that precedes the specimen actually coming to our lab. But
Right.
I think patients should always be an advocate for their own health and ask, not really shy away from asking questions about
Yeah, thank
this.
you for answering the questions. And again, a wonderful reminder to our audience that you're, in fact, are not seeing patients yourself directly, but this concept of educating yourself through
Yeah,
a conference like this, to know that there is a myriad of interesting, novel, incredible new tests to help with treatment and diagnosis is very important, and understanding that landscape and knowing how to enter and have a conversation around that landscape is very important.
yeah, no, that is
So,
very true. And they can direct you to very helpful websites as well. It's always better to sort of, get some guidance because you can find a lot of things online. You want to make
100%.
sure that, yeah.
Do you have a favorite that you'd like to share, and we'll make sure that we capture and put it in the chat? Anything off
Um,
top? And I don't
so
want
the
to put you
ones
on the spot.
yeah. So because the ones that I generally go to, I don't know if they might be very helpful for patients
Yeah.
because you have to first familiarize yourself with a lot of terminology before you can sort of appreciate what these other databases that I look at will tell you. But I think I might be able to email you some, which maybe you can forward to the audience.
Why don't we make a note of that? The team at Colorectal Cancer Canada will happily collect information on how those in our audience who definitely want to educate themselves more. It's a complex subject, there's no question about it. And
Oh, yeah.
having that additional education with your guidance would be very, very helpful. So, as a follow up to our audience, we'll ensure that we publish a number of interesting websites to support the amazing conversation that we've had thus far. So, one of the questions here, and it's a build a little bit on what we've just been talking about, is where can I find the results of my genetic testing? What document should I be asking my doctor for?
So you can always ask for the pathology report. And if there was any molecular testing done, you can ask for that as well. Now, sometimes, depending on where you're like which hospital you're at, those results are available through sort of a portal. So I work at UHN, and I know, for example, if there's any kind of testing that I've done at UHN, I can go through my UHN portal. I know across the street, Mount Sinai has a portal for their patients. And usually, when you are registered as a patient at the hospital, you are told about accessing, and so you're given a username and given instructions on how to set up a password so you can access all this information. So you can do that. If the hospital you're at does not have that facility, I think it's always best to just ask your oncologist, how can I get I would like the results of my pathology report and testing, molecular testing, if anything has been done.
Mm-hmm. Yeah, and on a really simple question then is on a scale of 1 to 10, where 1 is super easy, I will understand all the information I see, and 10 is, oh my gosh, I'm really going to need to have a second conversation with my team to understand that. What is the value in having these reports, especially when they might be overly complex to read? On that scale of 1 to 10, are they easy or hard?
Well, I think it depends on how much reading you do around it, right?
Fair
So
enough.
I think if you
Yeah.
go in cold and just look at a pathology report, it would be sort of hard to understand what they're referring
Right.
to. But I think if you read a little bit around it, then, because, like, for example, the Mayo Clinic website, they have great links for several different types of tests that are actually sort of catered towards patients to explain what the test is, how it's done, and what the results can and cannot tell you. And so if you have access to something like that, and Mayo Clinic, for example, it's accessible to anyone. You can just go Google Mayo Clinic and
I find that
you'll
is a
get
really
all
good
sorts
site.
of, yeah. So I think it depends on how much reading you do around the report. So
Mm.
if let's say you're going to you're going to get a test, and you're talking to the clinician, you can ask the questions then. If not,
Mhm.
then afterwards, after some a test has been performed, after you have a biopsy, for example, or an operation, I think you should be able to ask your clinician questions about the report to get access to it and ask questions about it. So it is, after all,
Yeah.
your report.
Yeah, I
So
know, and I love how you've reinforced that. And we've got a session at the community conference here about advocating for yourself. So, we're going to share websites. We're sharing information increasingly that you can ask for as a patient. It really asks you to learn more about your situation and to be very proactive with your team to best manage your treatment for yourself.
yes, yes.
Now, another technical question coming in from our audience is, can you explain what MSIH and MSS means? We see a lot of these new trials going on in Canada.
Yeah, so MSI, it stands MSI high, so H is microsatellite instability high, and then MSS is microsatellite stable. So in our DNA, we have these short stretches of sequences that are pretty stable for a person. Now, when you have a tumor, what's going to happen is when you compare the profile of these sequences in your blood and in your tumor, you'll see that in the tumor, it can be longer or shorter. And that's because if you have a mutation in one of those Lynch genes, these sequences, when they're being replicated or even actually repaired, are not done properly. So you have expansion and contraction. And so this test that they do, microsatellite instability, which is a molecular test, looks at the differences of these short stretches between your blood and your tumor. And if they see differences, like the satellites are expanding, when you look at the profile, then that means you have microsatellite instability. And generally, the standard is to look at 5 unique sequences. And if you have like 3 out of the 5 that are showing these expansions, then you have microsatellite instability and say MSI high. However, if the profile is the same between the blood and the tumor, then it is stable. So microsatellite stable.
Thank you very much. And thank you for making that such a simplistic overview on a very complex topic in general. We're going to have to call it a day on the questions, even though we've got dozens more coming through just out of time. We're very privileged to have you for our Q&A and for your wonderful expertise on the panel today. Thank you, Dr. Selvarajah, very, very much for joining us today. We are now moving. Yes, thank you. We'll see you again. I'm sure this conversation needs lots more in-depth discussion. I know that it's going to be a focus and a feature of more work in the future that we do together.